You guys hear me? Okay. Good morning. I know it's early, right? I just want to thank everyone for having me again. I really have enjoyed this. This is a great symposium. I've been to a lot of different ones. This one's awesome. You know, there's a lot going on. And the food, right? That's always sells it. That's how you get a nurse's heart, is you feed them, right? That's where like, yes, we got pizza last night. All right, so I'm going to talk about outside the norms when trauma strikes special, unique, and special population. So here's some learning objectives. You know, we got to have those, right? So I'll give you a couple of minutes to review them. Again, I have nothing to disclose. I am here on behalf of UF Health. Again, I hate the color of these slides because it's orange and blue, and I feel like everything should be garnet and gold because I am a Florida State fan, but it's something I have to deal with. That's a personal issue. I am here representing them. Oh, did I just see a, oh yeah, let's go Knowles. All right, so I was going to let you know too that the honorarium that I'm getting, I mentioned this yesterday, I am donating it to the hospital, specifically to my nurses that are at bedside, so that I can send them, hopefully NTI's in Orlando next year, so that's super close to us. So I'm hoping to send 3 to 4 nurses. That's my goal. We were unable to financially send anyone this year, and that's a bummer. I think they deserve it. They work hard. So that's my only disclosure. But if anyone wants to pay me to do something else, we can talk later. I'm always willing to take donations. No. Anyways, let's talk about the scope of this problem. So about 1 in 60 people have autism. There's some form of on the autistic spectrum, right? About 2 to 3% of the population is intellectual disabilities, and it seems like a low amount if you think about it, but that probably means that we're not identifying them, and they could be even we're even less familiar working with intellectual disabilities, right? We're not as good at it because we don't see them all the time. Cerebral palsy is another one, and there's a couple of others here listed. It could be from a spinal cord injury, blindness, deafness, speech disabilities, short stature, Tourette's, seizure disorders, things like that, psychiatric disabilities. These all kind of go up underneath this unique population. So this was a study that was done in 2012, so it's a little old now, but it actually talked about, it surveyed a pretty large population of special needs patients and their interaction with nurses. How do you think that went? Not well, actually. We kind of stunk at it. And nurses, we pride ourselves on our patient satisfaction, right, and how well we take care of people, but we actually didn't do that good of a job, all right? Poor communication by the nursing staff. There was compromised care or lack of competency, they felt like. This is per the patient. Negative attitudes. They felt like they were second-class citizens. Fear related to their quality of care. That's not cool. None of us get into this to hurt somebody or make them feel bad, right? They already feel bad enough they're in the hospital or they've had a traumatic injury. So this is not a good thing. How many of us do this? I've done this. I'm guilty of it. If I think there's some sort of a intellectual disability or even my elderly, I like scream at them. My voice gets really loud. Does that mean they're deaf? Not necessarily, right? I talk fast. I talk over people all the time. It drives my husband insane. He can't get a word in edgewise. Not that his word really matters that much, but anyway, so, but I talk over people and I don't give them enough time to respond. And sometimes with these patients, you need to give them a few minutes to get their thoughts together and to be able to get that out, right? No one should be fearful of their quality of care when they come into our institutions. That, I feel, is and be felt like a second-class citizen. So why does this matter? Well, because of the patient themselves, it should matter. Because we do this because we want to help people, not hurt people. But let's be honest, healthcare now is all about reimbursement. Anyone get the fun of looking at HCAP scores regularly? Yeah, those are good times. Okay, in the SICU where I work, we have 28 patients. Pretty much most of the time we run about 17 to 20 ventilators each shift, each day. Most critically ill. Do you know how many people we discharged from our unit? We did 6 in 4 months. Do you know how many people responded to our HCAP scores? 1. Hey, we were great. We were all in the green. I was like, this is awesome. Look at that unit. They had 300 and something discharged, but we're all in green. But it's not accurate, right? But this is how we're being reimbursed now, right? This is how the government's funding us and deciding which hospital they're going to give money to. So this is important, right? So every patient, it makes a difference. So let's talk about autism. It's a huge spectrum, right? Because you can have somebody who maybe has Asperger's, which is more of like a social disorder, all the way to an autistic child or an autistic adult who's nonverbal, and it doesn't mean that they don't understand necessarily, they just may be nonverbal. And so there's this nice little diagram, and all of this kind of goes into the autistic spectrum. They can be very challenging patients to try to communicate with and to try to understand what they need, right? Behavior can be an issue. Because they can't communicate, what do? They act out a lot of times, right? Because that's their only form of communication. So that's something we have to keep, in the front of our minds when we work with these patients. So, like I said, communication. This is a nurse at Shock that I work with. She's still there, Megan. She's great. It's such a good picture of her. Anyways, so language. Is their language delayed? Or do they even have a form of language, right? Can they even communicate, like I said? It's a big problem. Most of our patients and most of the things we do, it all boils down to communication. If you ever do any PI work, you get to go back and look at stuff, it almost always comes down to communication. What about this guy? Anyone ever seen him? You think he's got some social awkward issues? I love that show. He cracks me up. Anyways, nonverbal behaviors, right? They may have issues with their peer relationships. Joint attention. Social reciprocity. Every time I say that word, mine gets tongue-tied. All right, so this is a trauma bay at Shock. Most of our EDs and trauma bays look like this, right? What happens when the patient shows up? We all ascend on them, and we strip them down to their birthday suit, right? We take everything off of them. We take complete control of the situation. It doesn't matter if they're awake or not or whatever, right? This is scary for the average American who doesn't have a disability. Anyone had the pleasure of riding on a backboard in the back of a rig and then showing up to a trauma bay and all these people show up and then they strip you naked and then you're cold and then you're like, what's going on? And they're poking me with needles and sticking stuff on me. It's not a good time. I got better things to do, right? I'd rather not be there. But imagine looking at it through a disability. Now it's kind of warped. Now it's even more intense. So we have to keep that in mind. So what do? So the best thing to do with these patients, and again, it all boils down to communication. Of course, your ABCs, right? If they're critically ill, you got to do what you got to do to save their life. But if you have the time, and if EMS picks up on the way in, hey, I think there's some sort of, some intellectual disorder going on here, or the family member reports that, they have autism or whatever information you can get prior to coming in can help you prepare. So maybe not have the bay full of everyone and their mother, and because I know trauma is a spectator sport, right? Everyone shows up. There's people from places in the hospital you didn't even know existed. The IT guy comes from across the street because he heard a level 1 was coming in. I heard the helicopter, right? So this is not the time to have a spectator sport, right? Crowd control. Maybe try the primary person who's going to be at bedside as the nurse to be the primary communicator. If they have a family member that they're comfortable with, right? Having that person be there. Make eye contact. That's a big one. We don't do that very well in general, right? What are we all doing? On our phones, right? Or yeah. Eye contact is important. I'm guilty of it all the time. I'm looking at my phone for stuff, But taking that time so that they know that you're there, it's comforting. Calm voice, not excited. I love me a level 1 recess too, I'm not gonna lie. But sometimes you gotta be that person to kind of be calm. Also, if you can forewarn them before you touch them. Like, hi, I'm Kristen, I'm your nurse. I'm gonna put a blood pressure cuff on you. Don't just grab the arm and throw it on there, because especially if they have poor communication, what kind of behavior might you see? A good swing, right? Don't touch me, right? I don't blame them. They don't know what you're doing. So we gotta tell them, we gotta have that time. Explain what they will feel. This is not the time to say an IV is a bee stick. Anyone been stung by a bee? An IV feels a whole lot worse than that, right? Be honest with them. This is gonna hurt. I have to draw blood. But it's all in how you say it. This is gonna make you better. How do you want to lay your arm? Try to help them, make them participate. Very similar to how you would with kids, but don't talk to them like a child, right? Be honest. I think that's in general, be honest with your patients. Don't say the CT scan's gonna be back in 30 minutes when you know it's gonna be 4 hours later. Or you're up next in triage, right? Because you know that's not true. Because it just depends upon what rolls through that door next, right? Make them feel safe. Make them feel like they're in a safe environment, all right? They've left the comfort of their own environment. And environmental changes can actually cause them to feel more angst and more anxiety, okay? Because it's the unknown. There are some great assisted devices out there nowadays. Thank goodness for technology. This is an actual chart. That's a pain chart that you can use. I know in Maryland, there was a lot of work with Baltimore City to have them start carrying these in the rigs because of the fact that they realized that there was some issues with communicating on scene. And so having some of these charts and things was helpful. So this is just one chart. The iPad, if anyone's worked with any kind of autistic, especially children, you see a lot of research on autistic children and things. It's actually the iPads and the apps is great. I have a good friend, she's a nurse, her son is extremely autistic. He's on the far end of the spectrum, he's nonverbal. The apps have made his whole world different. He's 10 years old, he was not potty trained, she was having lots of issues. She started using these apps and some of this behavioral stuff, and they're able to accomplish a lot. And he's now able to actually communicate what he needs. So these are great. There's some free ones, there's other ones, this is just one in general. So they're really great. Okay, let's talk about cerebral palsy. I have a cousin who has cerebral palsy. She is wheelchair bound. Not all are wheelchair bound. But a lot of times they have jerky movements because of the rigidity of their muscles, right? So she does. Slurred speech, that's very common. One of the things that happens with her is that her eyes have a hard time focusing. So you're looking at her and her face might look at you, but her eyes are kind of drifting and they'll actually drift opposites. You know, it seems kind of weird. Sometimes they move back and forth and you might think, oh, is she having a seizure, right? So sometimes there's slurred speech and there's delay in speech. This is where you give them time to answer. So you ask a question like, how is your pain? Intellectually, she's 100% there. She can speak, but you have to give her some time to actually explain, to actually talk. So sometimes they appear like they're drunk, or you're like, what is going on with this person, right? Mm-hmm. Don't always act on your first impression. We're really bad about that, right? Oh, that's the drunk guy again. Oh, that's the whatever. Don't do that, right? We need to actually figure out what's going on, get all the facts. It is helpful if there's family or friends or a caregiver there to help fill it in, but as we all know in trauma, that doesn't always happen. Listen, give them time to answer. Don't take away their assisted devices. Kind of like I talked about the prosthesis yesterday. They like to hold on to them in my ED, right? Same thing, that's their form of mobility, right? So if I take away their cane or their walker or their AFOs, that's their way of them being independent. And now I've taken that away from them and not allowed them to use it. Now I've taken away their form of independence. I love Lauren, my cousin, but she sometimes is a little socially says things that I would consider awkward. So don't be offended if they say something that seems, yes, she has told me, that dress is tight. Are you fat? She said that. I was like, oh, never mind, okay. Right? She's just being honest. It's like a child, She's just being honest. She doesn't have that. A lot of it because of her disability, that social interaction is delayed. So that's some of it. All right. So I'm going to talk about a specific patient that a nurse that I worked with, Bridget, took care of. I was there that day. And so it was a high-speed crash, multiple rollover. This was when I was in Maryland. Her arm was partially amputated. You guys are going to think all my case studies have to do with amputations now and stuff, but they really don't. And left open humeral fracture, okay? So she arrives. This is her x-ray. I'm not a doctor, but I'll say it's broken. Those bones don't lie up. It was a very strange, normally you would expect a young woman rolling in would be screaming and crying, and there was nothing. It was a very flat affect. It was very strange. We didn't know what was going on. We were like, it just seems weird. She's not really responding to us. She was by herself, so she'd ask questions, but it took her a few minutes. She was a little delayed in answering, and there was a lot of yes, no type answers. She had this just this, I don't know how to explain it other than her, like, she would just like lay there. And you'd be like, okay, we're gonna do whatever. And there'd be nothing, and you'd be like, most people would be like, okay, thanks, or, oh, can I get some, more pain meds, or nothing, okay? But we really didn't have time to mess around because that's broke. So she was in the OR pretty quickly. She got scanned, nothing else was wrong. She made it into the OR within 39 minutes. Here it is, all fixed. Looks lovely. It did great. She was able to keep her arm. We didn't find out until later, when her family finally showed up, that she had a history of hypothyroidism and she had Turner syndrome. It's a really rare disorder that affects females, and it's a sex chrome abnormality. So we're all like, Turner syndrome? What is this? I've never heard of this, So we did some research, and we all looked it up, and this is some of the things. They can have hearing loss, hypothyroidism. Well, that makes sense, right? Liver function abnormalities, renal abnormalities, cardiovascular disease like hypertension. She was young, she was in her early 20s. She did have hypertension, diabetes, autoimmune disorders. But she was of normal intelligence, but she had a hard time verbalizing, and that is part of the Turner syndrome. She had impaired nonverbal skills, social cognitive problems. Well, that explains the flat affect, the inability to actually talk to us, right? It might have been nice to know in the trauma bay. I mean, it was only 39 minutes in that trauma bay, which is actually a long time. But it would have been nice to know these things because maybe we could have comforted her better. We didn't. We didn't assume anything, and Bridget, who is the primary nurse, is great. She's very motherly to her patients, and they love her. But these are some of the things, and it says problems driving. Maybe she shouldn't have been. Could have been part of the reason why she was. But 3 months later, according to her clinic file, she's actually weaned herself off narcotics. How many of our patients do that? Not many without assistance, right? We usually have to help them, and they're like, but I want the pain to be 0. It's not going to be 0. She actually had some phantom lip pain, but they used other means of medication and not narcotics. She was a hostess. We saved her arm, and she was able to go back to work, which is awesome, right? We didn't take her out of the workforce. So is there any questions about working with special needs or anything like that? I think I'm right on time, right? I'm supposed to go right into another lecture, so. Any questions about any of that? All right. So I think I go into my next one here. Let me find it. So now we're going to talk about documentation. This is the best. Everyone gets so excited about documentation. It's my favorite thing to do. Just kidding. So if anyone's had the joys of doing audits, electronic medical records, EMRs, or EHRs, electronic health records, have become fun. That's how I put it. But there's a way that we can CYA our EMRs. Some learning objectives. Okay, again, same disclosures. We'll skip that slide. Except for the fact I am going to complain one more time that it's orange and blue. Okay, so what is electronic medical records? Okay, how did this come about? Okay, so actually it had to do with the American Recovery and Reinvestment Act of 2009 is actually where this kind of started. I didn't realize this until I started researching for this lecture, that I thought it was like, oh, we're going to make better healthcare. Oh no, it actually had to do with trying to help jobs in the IT world. The IT world kind of crashed and burned, and so the government said, well, maybe we can promote some jobs. They put $25.9 billion towards it. And then they said, well, it'll also help a goal of deliver excellent customer service. Not better care, customer service, because why? That's how we get reimbursed now, right? Those HCAP scores keep coming back. And it also promised to pay the maximum amount. I don't know that that's happened yet, but it's supposed to make things a little bit better. If you did not have an electronic medical record of some form by 2015, there was going to start to be large penalties. So we all know the big scramble that every hospital had, right, to go to electronic medical records. So Affordable Care Act in 2010, part of it was to promote healthcare financially, technology, and clinically. And the goal at this point was then to improve healthcare, decrease costs, and make healthcare benefits available to more people. with having electronic medical record. That was all of our goals then. Okay, so there's some pros to them, right? There's some good things. So better storage, right? You didn't have to, like, for a medical record, anyone have to go back and get their files? I did when I was going to nursing school. I was military growing up, and going to the Navy base to try to find my immunization record was like a 3-month process, because they had to find it, and it was stationed some other place where it was located, and they had to request it, then it had to come in, then they had to copy it. So it was quite the ordeal. So better storage, right? Because now I can just type into a computer and print. Eliminate missing information. So it will all be together. So this whole, oh, you have this part here, vital signs are here, and then that sheet got from there, and then you had to try to find it, and how did this paper wind up in that person's chart, you know? You can see chronological documentation, which is great for our patients, because a lot of our patients come back multiple times, right, because of their chronic disorders now, with having, you know, they see ortho and they see this, and we can say, oh, well, this was the date of their trauma, and here's all of the information. You can kind of see how it goes. That makes sense. Streamline communication and patient throughput, right? It's supposed to help us communicate better. So that I can send, we use Epic where I am. I've used primarily Epic. I don't know that there's one better than the other, but in Epic you can send like a sticky note to the doc and they can get it. So if they're like rounding or whatever, then it sends them a note and then they can kind of respond. So we don't have to, you know, page them. They break away from rounds again. Now they're mad. You know, I'm sorry, I need a Tylenol order, right? Reduce medical errors. This has actually happened with medication for sure. At our institution, we went to the barcode scanning of the armband and the medication, and we are not allowed to overwrite it unless it's an extreme emergency. We have a DEA retired detective who hangs out at UF Health that we've hired. He reviews every, not only narcotic, but every medication that you skip the scanning process. Because it has been shown that if you do the scanning, you'll get the right patient, right route, right time, right medication, the 5 rights. So that has definitely helped reduce medical errors. More accurate patient history, right? Because now I can review the last time this patient was in and know, oh, they were on a beta blocker. That's why their heart rate's only 40. No. Charge capturing, so to make it easier for billing. Promote preventative care, right? Anyone get all those alerts about immunizations during flu season and all that? Constantly, every day, right? So it's supposed to help with that. And e-messaging. Here's some cons. Not all networks are connected. So if my patient goes to our institution and then goes to another institution across the street, even if we both have Epic, I can't see what they're doing, they can't see what I'm doing, right? They don't talk because we're 2 different institutions. Our firewalls do that for protection, right? If I have a patient who is seen here and somehow winds up in Jacksonville, I have no idea what has happened here in the medical record and what's happened there. HIPAA violations. We see this a lot nowadays, right? Our information's being released and hacked and all of this, right? So this is how you can have this happen. Firewalls are huge, you know, in hospitals. Decrease in productivity. It does not make it any easier, I think, to document on the computer, right? We end up doing a couple different things. We can make typos, things like that. I think this is a big one though. It decreases face-to-face conversations. I'm no longer speaking to that physician. I'm now sending him an e-message or a sticky note. You know, and sometimes that face-to-face conversation is worth a lot. You can learn a lot about a patient or about what's happening. Outdated technology. Who had to get new computers when it all came on? Because guess what? Our old computers wouldn't have it, right? We had to do that. The cost to set it up. Millions to billions of dollars at large institutions. Inova Fairfax, or Inova in Northern Virginia, has 5 hospitals within it and multiple clinics and outpatient centers and rehabs and all this stuff. It costs them nearly almost $1 billion to go to an electronic medical record. But here's the catch. Why didn't I get into IT? I really probably should have, right? Because here's the catch. Just because you got it doesn't mean you have the latest update. You have to pay for that, right? You want to run a certain report? Oh, you got to pay for that. That's additional charges, okay? Auto-population into empty fields. There are some versions of electronic medical records that will auto-populate, and if you don't go in and approve them or not, it'll just fill in the blank. This is the worst one. I can't stand this one. Copy and paste feature. Don't ever copy and paste. You're going to hear me say that a million times. I cannot tell you how many times I went back and audited a chart for a PI issue, and they still say the patient is a GCS of 15, but the patient is intubated, sedated, or they're an organ donor for brain death. But yet it still says they're a GCS of 15. It's copy and paste. I see it all the time. We had an issue. It doesn't sound like it's a big issue, but it really could have been. I had several nurses, 5 actually, who were documenting that the dressing for the central line didn't need to be changed for however many days. I looked at the central line. The central line had been changed, the date had been changed, but they kept putting the 10th. Well, the 10th came and went, and then it was the 30th and the whatever, and they were still putting the 10th that was due of the previous month. So when they moved to the next floor, they said, this documentation's wrong for like 5 shifts, you know? Because people were just copying and pasting. You weren't thinking about it, right? And 79% report that the EMR does not meet their needs. Again, if you've ever had the fun of auditing, to try to put the pieces together can be very challenging, very challenging. And we have just culture that we function in UF Health, so we don't just automatically say, oh, she did it, he did it, it's their fault, right? No, what we do is we investigate, we review, we look at everything. But to do that, there's so many different screens, so many different reports you can pull, and if you pull that report and I pull this report, they may say 2 different things. So what is CYA? I know what you guys all think it is, but it's cover your assessments. I have a 3-year-old. We don't even curse. We say HE double hockey sticks in our house. So it's cover your assessments. So what does that mean? So charting by exception. This was a great idea. When I started in nursing, we wrote everything down. I wrote like a dissertation on my ICU patients. And then we went to the fold-outs with the check boxes. So I'd do that, then I'd still write a dissertation. We'd have to copy the blank form to fill it in for every shift, right? Well, then we came up with this idea, well, why don't we just chart by exception? It's a great idea if it's used properly. It's not a shortcut. It doesn't take us time. Okay? Charting defensively. What does that mean? I'll go over that. Document everything, and I mean everything. I got called into the director's office when I worked in the ED because there was a family complaint. I had spent half my shift in this family's room, right? I thought I had a great relationship with them, everything. A couple days later, I get called in. Nancy and Jody. Nancy was my director, and Jody was my manager at the time, and of course, they didn't complain to me, they didn't complain to charge nurse, they didn't complain to the manager, they went all the way up the chain, so then it came all the way back down, right? And they're like, this family says you never went in that room. I'm like, you're killing me, I was in there every 2 seconds. We ran out of pillows and blankets because I gave them so many. Well, where is it in your documentation? I mean, I did the minimum document, I documented what I was supposed to. Yeah, but did you document that you gave them a pillow? Because I can't prove that you did it. I was like, can you pull the videotapes? Pull the videotapes in the ER. Prove that I was in there. They're like, no, but you didn't document it. Sounds minor, but I was like, man, that stinks. And of course, because it went all the way up the chain, this was not a just culture at this hospital, hence why I don't work there and haven't worked there for a long time. I got a write-up. The one and only write-up I've ever had in my entire career. Over pillows. And then there's these, remember the nevers, which we'll go over. Okay, could this be you? 5 years ago, you had a patient who died after his condition became worse during your shift. You're pretty sure you remember calling the physician and pretty sure you told the oncoming staff this patient had passed away. All of a sudden, you get called into an office. A meeting shows up on your Outlook calendar. That's what happens to me all the time. Now you're being named specifically in a lawsuit against the hospital for the wrongful death. No problem, I documented this. Let me just go back and look. You review the chart. It shows that you called the doctor and passed the information off on during your report. But it's actually not there. You're pretty sure you did it, but it's not there. Do you think you'd be found at fault? Absolutely. personally. And the hospital can say, oh, you practice on your own. That was outside our policy and procedures. You're on your own. Good luck. Now, I'm not saying we should document or change our behaviors or anything based off of lawsuits, but this is a reality in our life. We have a case right now of a family a patient who developed a bed sore, and they say that it started with us. And they went on to a rehab center, were there, came back multiple times, had to have it debried. The documentation is so poor, the nurses did not know that the patient actually had it prior to arrival. Guess who's writing the check? Not the rehab where he got worse, and he actually went all the way down to a stage 4 and ended up dying from sepsis. We did, because we didn't document it. The wound care nurse was consulted and saw the patient. They ordered a specialty bed. Why would we order a specialty bed on a patient if they didn't have a wound? The wound care nurse also did not document. They just ordered the specialty bed. We now write a big fat check. And then that affects me because then I can't get a raise. It's all about me and how I get more money. So, charting by exception. So again, this is not a shortcut. It requires judgment and expertise. I don't feel like our brand new, unseasoned nurses, as we like to call them, should really be doing this. They need to know what the exception is, and they're still kind of figuring out what the assessment part is, right? Only exceptions are baseline findings are charted. Know your facility's definition of within normal limits or baseline. We do not have a formal definition at UF Health, so I tell my nurses, do not document that, because your normal limits and your baseline are different from mine. I need to know what is that. And just because nothing's written doesn't mean it's normal. You have to remember by charting by exception. Some of our patients, normal, for like normal skin, might be different for you and for me, right? So that's why it needs to be documented. Okay. One of the things about defensive charting is you need to just ask yourself, am I creating a clear picture? That's the whole thing. You want to tell the story. You want to tell it from top to bottom, okay? Am I charting to alert a provider about the patient's changes or findings? If the next coming shift or during rounds, they look at these vital signs or they look at what's happening, can they tell that this patient is circling the drain? Right? Is my charting mechanical almost? Rapid clicking and scrolling. And then I go back and I'm like, why did you document that? Sorry. Yeah. I was just clicking. I had something else to do. I got 3 phone calls in the middle of it. I had a patient, screaming. I had another one I had to take to CT emergently. So I was just clicking and scrolling through. I wasn't actually actively involved in documenting. And yes, I say document everything. I had another case where I was at shock trauma. I had a patient who came in the middle of the night when I worked night shift, who EMS told me, oh, this is Mr. So-and-so. We pick him up all the time, and we usually take him to the ED because he's a heroin addict. He's found laying on the ground. He says he can't move. Because he was found on the ground and says he can't move, we have to bring him to trauma because we think he fell off this fence or whatever. But he's probably just high. Give him some time to sober up, and you probably get him out of here. All right, whatever. So he comes in. He's a little cooperative. With some Narcan, he's a little more awake. We scan him. But I noticed that his neurological assessment is really odd. He really cannot move his feet. He cannot feel me. And his arms are like floppy like this. He's doing the chicken wing. And I'm like, I don't like those. So we scan him. Everything comes back normal except for his neck looks like there's some degenerative findings. Like it looks like his neck's kind of, messed up. It's like he's older. So the resident comes in and says, she was a visiting resident during her rotation, and comes in and she says to me, we can take his collar off and clear him. He can go home. I said, I'm telling you, there's something not right about this guy. She's like, no, just take his collar off. Well, I refuse to take his collar off. So she comes over and sits him up and takes his collar off. And what's he do? Slumps to the side, right? We go back and forth. Finally, I'm like, okay, I've had it with you. I'm going higher, right? Go follow my chain of command. So I talk to my fellow. My fellow's like, let me talk to the attending. The attending's in the OR. He's had a terrible night. He's like, look, I looked at the scan. It says fine. She's telling me his exam's good. Just get him out of here. I'm like, I'm not calling his family. By the way, it's like 3 a.m. So I'm like, you know what? Let's just let him sleep it off. We weren't slammed. We weren't busy. I said, it's okay. He was cooperative. Of course, I laid him back down. And I put his collar back on. She calls his brother, who shows up at 3:34 in the morning. She says he's being discharged. And she's like, come on, get up, get up. And he's like, I can't move. I got this burning sensation everywhere. And I'm like, I'm telling you another time, something's not right about this guy. I'm telling you, and I'm documenting this as we go along, and I'm documenting, spoke to charge nurse, spoke to, so-and-so and so-and-so, and I'm not calling anyone out like I wanted to say she's an idiot, but I didn't. I kept that to myself, and so anyways, I document all this stuff. And very early, it was about 6 a.m, the attending who was on, we barely saw him, he was in the OR all night with some ICU patients. So he runs in, gives a quick blowdown of what's left here, leaves, trusting that his fellow and that his residents have done good exams and everything. And the oncoming attending comes in, and I pull the oncoming nurse aside, and I said, look, this don't look good. Chart. And it turned out he was emergently rushed to the OR, and he's a paraplegic. I don't think we would have changed the outcome, but 2 weeks later, I get called into a big boardroom with all these people, and they're like, can you explain your documentation? I'm like, well, it's right there, what I found. Well, why is yours so different than hers? I said, I can't explain her documentation, I'm not her. I wanted to say because she's an idiot, but I didn't. You don't do that, you can't call colleagues like that. So I just said, I can't explain it, here's my documentation, right? And it covered me, it saved me. It was what I really saw. I documented what I really saw. Now, I'm not saying that I don't think it would have changed his outcome. I think he was a para as soon as he rolled in. But we quickly made judgments. He's a heroin addict. He's always here. And it saved me, though. Because I really think that the hospital would have been like, whoop, that's on you. What happened physician-wise, I have no idea. She was a visiting resident. She finished her, and she moved on. So can you convince a judge or a jury with what you're documenting? A layperson. Anyone had to testify? It's good times, huh? Yeah, that's how I want to spend my day off. Yeah. I've had to testify for blood alcohol. Thank you, Anne Arundel County of Maryland. They call you in. They'll put a bench warrant out for you if you don't show up. Do you know how intimidating that is to sit there and try to tell a judge and prosecutor and a defense attorney, and they're trying to prove that you don't know what you're doing, and I'm like, I know how to draw blood. I mean, hello, I work at shock trauma. If I don't know how to draw blood, maybe I need a new job, right? But I have to prove that to them. It's not fun. And then I had to pay for my own parking at the courthouse, which really made me upset. $4, and I can't get reimbursed at work, and I only got paid for 2 hours of being the 6 hours I was there. Just saying, I have a little negative outcome on that, right? Little upset about that, not bitter at all. Anyways, it's not fun times. You got better things you'd rather do with your time. The biggest thing I can tell you is know your facility's policies and procedures. They were put there for patient protection and for you. I can't tell you how many nurses I say to them, our stroke patients, for example, what is our policy and procedure post-TPA vital signs? Well, my preceptor told me, I don't care what your preceptor told you. What is our policy? Know how to find them. Follow them. If they're not right, yes, it takes an act of Congress and God to help you change a policy and procedure. But if it's not correct, it's not what you're following, it's not your actual practice, then you need to help create that, right? You need to change that to what you really do practice based off of best practice. Okay, here's some nevers. Frequent flyer. ETOH on board. You could say, I have the smell of ETOH coming from their mouth. Or whatever came out of that NG tube is definitely tequila, right? But you don't write that. You have to write large smell, brown liquid with smell of ETOH to it, right? Or maybe not even say that. Just describe the liquid. They're acting crazy. What does that mean? They're doing well. What's well? Well for them, well for you. If they're that well, why are they here? No change. That's my favorite one. No change from what? From the previous shift, from the day before, from the last assessment, from the what? What does that mean? I've written that, no change. It doesn't mean anything though, right? Love this. Okay. As much as I want to sometimes write this, we all have those colleagues that we struggle working with, right? We'll all admit it. The patient's chart is not your personal diary. Don't talk about how Nurse Betty left the room a hot mess and I had to spend half the day cleaning it up, right? Doctor refused to see the patient and then was rude to us. That is not the time or place to discuss it. I love this one. Due to nursing short staff, which I've seen this, patient did not get medication. Don't put that. That's not an excuse. That's not good. Right? We still got to function. That's something you need to take up with your manager, and there's other ways to handle this. This is not your personal diary. In another patient's room doing dressing change, so I missed it. Oh, I missed the plan and rounds due to being off the floor with another patient. Don't say that. It's still your responsibility to figure it out. These are real things that we've seen. Okay? Charting before it's done. Anyone done that? I did that earlier in my career. I pulled out a medication, charted that I gave it, went in there, and then the patient refused it, and I was like, oh, son. Right? Then I had to go waste it, and then I'd go back and fix my charting, and then that took me an extra 10 minutes. Oh, but I got distracted 5 times on the way. Right? Charting something you didn't understand. Well, I'm just documenting these ICP numbers. Are you supposed to do something about them? You mean 50 is not okay? Oh. Maybe I should have done something about it. If you don't understand, find your resource person. Ask that person. Right? Ask somebody, how do I document this? I had a patient who had a lot of different wounds and things, and he ended up having some of the rash and stuff came from the chest tube dressing change that he had, and it had ripped some skin, and the nurse was like, how do I write this? I said, this is what you're going to write. See what you see? That's what we're going to write. Right? Changing or adding documentation. We can do that. You have to know your state and your policy for your hospital. But what you need to do is put the current date that you went back and changed that. Now, with EMRs, it's time-stamped, so don't think that you're going to go back and document it and that no one will know that it wasn't done. I had a nurse who missed a restraint documentation, and at our hospital, you get called back in. Okay? We check it every 12 hours, and if you've missed documentation, I don't care if you just got off a shift and drove an hour home, you're driving back to the hospital to fix it. I don't care if you're back that night, you're fixing it then. So, needless to say, we don't miss a lot of restraint documentation. But they come back, they fill it in for the 2 o'clock or whatever time frame, right? Well, guess what? That's time-stamped of when you actually did it. So it's not like, oh, I actually did do it and now it's on there, right? So, oh, it was actually done. No, you need to actually timestamp it. If you go back and make a note, you need a timestamp when you actually did it. Okay? It's okay that you forgot something. I do that. I'm halfway home and I'm like, oh, I forgot to put in whatever. I forgot to document whatever, or I forgot this part. It was so crazy, everything that happened. Trying to get my thoughts together to get it in there. You know, I needed that time to go back and think. If you know it's in litigation or review, don't touch it. Okay? Because they'll use that against you. Ooh. Okay, so I have this great video, but I don't think it's going to work.